Okay, guys, today's lecture is on the shoulder, really the shoulder complex. It's a multitude of joints. So when we just say the shoulder joint, really, we need to be specific about what we're referring to. So throughout this lecture, we're going to point out different joints along the way. First and foremost, we always need to understand osteology. If you don't understand the way the bones line up, well, it's pretty hard to move forward from there. So let's go over and take a look at those guys. So quick frontal view here. And these are where you're going to start to see different joints here. There's four major joints that we need to take into consideration. One is your sternoclavicular joint. What's nice about the joint names generally all the time is the name tells you where the joint is. So the clavicle and the sternum right there. So that's joint number one. Joint number two, the acromioclavicular joint. So we should already be able to find the acromion. So one of the next things we need to do is start finding where the AC joint is. You'll see this called the AC joint a lot, acromioclavicular joint. Then we're going to have the glenohumeral joint, which is what most people are referring to when they say the shoulder. But really, this is the whole shoulder complex or the whole shoulder girdle. All of these joints have to work together to make you have the optimal motion that you generally see at the shoulder. So your glenohumeral joint, the head of the humerus and the glenoid fossa. And then the often overlooked and missed, not considered even in the clinic, scapular thoracic joint, and that is between the rib cage and your scapula. So that's super important. All four of those need to work so that you can have normal motion at the glenohumeral joint. Let's take a look at the backside here. So what I like about this picture is just showing you all the different insertions of the muscles themselves. So taking a look at that anatomy there real quick. Nothing major to really point out that I can think of. So we should understand how the sternum, clavicle, scapula, and humerus all work together to create our shoulder girdle complex. So now we talked about those joints. I talked about the sternoclavicular joint. Talked about the acromioclavicular joint, as I said, also called the AC joint. With this one, I'd like to add, and your book has tons of great little clinical insights you should be I said that because I'm about to say this, should be taking a look at, but the step deformity. What is that? So if you have an injury to the AC joint, you will oftentimes have what's called a step deformity. So take a look at what that is. That'll be in your PowerPoints, or you can always Google it too. And if you find the answer, put it in the comments section. I'll let you know if you're right. And then the third joint, scapulothoracic, scapula and the ribs. And then the one that we're actually generally doing measurements of for GONI is the glenohumeral joint. But again, that is dependent upon the other three joints moving correctly. And we're going to talk about that rhythm in just a second. At the GH joint, it is a ball and socket joint. So make sure you're taking a look at what all the other joints are. I have it written on here so you can see that as well. But so we understand each joint is a little different, but they're all synovial joints. So some big things that happen at this joint, of course, is we're going to have the rotator cuff. So we need to know the four muscles that make up the rotator cuff. So number one, supraspinatus. Number two, subscapularis. Number three, infraspinatus. And number four, teres minor. So that's the first thing you need to know, are the four. Then you need to know the actions of each and what it does. And then you need to know the nerve, so that damage to the nerve will lead to weakness of motion because of one of these muscles being affected. So we need to understand that process there. Then you have the general joint capsule itself. You have a ton of ligaments. The coracohumeral ligament is one we'll talk about here due to pathologies here in a second. We have the labrum. So if you remember with the hip, very deep socket, and the labrum also helped add to that suction. But even though the shoulder is a ball and socket joint, as I presented up here, and it does have a labrum, it is still much less stable, but it has a lot more motion. So we sacrifice stability of that joint for an incredible amount of motion. And long head of the biceps, which we'll talk about that as well when we get into some other pathologies. So I want to talk about this situation here called static passive locking. So let's go over here to that. And we'll talk about the rhythm. So if we're thinking here about the head of the humerus and the glenoid fossa, because it's so shallow, you can see in this picture, if you look over here at picture 2, that there's not much holding the head of the humerus in there from a structural standpoint. So muscles and leverage, that's going to be the key. So it's actually important that our scapula is upwardly rotated just slightly, because what that does to the compression force, since gravity is constantly pulling down, it helps give a little more pressure directly into the scapula and that glenoid fossa to give it a little more stability. So the rope represents, imagine this being your upper traps. So it's helping upwardly rotate that shoulder. And we'll talk about the rotations in more depth in just a minute. So when you have weakness of the upper trap, you lose that upward rotation, and now the shoulder starts to move inferiorly, which can of course cause pain, but also makes it more susceptible to dislocation. So we'll talk about this even more in neuro, but if you think about someone who's had a stroke, and if their upper trap is affected, shoulder dislocations are a thing that we need to take into consideration. So that's where you'll see this play out a lot. Now let's go to the scapular rhythm. So with this, I know there's a lot going on in this picture, so let's try to dissect this. First, we need to understand that there's a 2-to-1 ratio. So for every 2 degrees of shoulder abduction or flexion, but we'll say abduction for right now, we can get to 180. But to get to 180 degrees of shoulder abduction, we need the other joints to be moving that I talked about. So for every degree or 2 degrees of shoulder abduction, there must be a degree of movement of the scapula. Now, the scapular thoracic rhythm, let's look down here, will give you 60 degrees of the range of motion. So I want you to understand that the humerus is not actually moving 180 degrees in that joint. Okay? You're going to get 60 of those degrees from the scapula moving upward. And if we think about this concept over here that I talked about, we need that scapula to upwardly rotate, to help maintain better congruency between the head of the humerus and the glenoid fossa. So we need that upward rotation. So we need 60 degrees of upward rotation. How do we get that 60 degrees of upward rotation? Well, that's a combination between the SC joint, your sternoclavicular joint, and the AC joint. So if you look at, you get 25 degrees here, 35 degrees here, that's 60 degrees. That gives you your scapular thoracic rhythm. So for every 2 degrees of abduction, we need 1 degree of scapular upward rotation. That rotation comes from the SC joint and the AC joint. So clinically, what happens, if you take someone's range of motion measurement and it's lacking, let's say due to an empty infield, that's probably what you're going to see, then we need to start maybe considering, besides joint mobs, we need to start looking at, well, is the scapula moving appropriately? And we can compare that by comparing to the other side. Just have the patient abduct and compare scapular movement. And if that's restricted, is it restricted because of, remember there's 3 joints, it could be the scapular thoracic joint. Is there adhesions to the rib cage or what's going on there? You could also look at actively, is there weakness in any of the upward rotators? We could also wonder, is there tightness or irritation at the AC joint or the SC joint? So those are things that we should consider moving forward. What is great about the shoulder is it does a lot for us, but clinically it can be a challenging joint, and you're going to see a lot of patients with this, whether it's skilled nursing, outpatient, or anything, because this joint, because of its lack of stability and its complexity, offers us a lot of different pathologies that could exist, which you will learn even more of in the patho class next term. So we just talked about that static passive locking and the scapular thoracic rhythm, 2-to-1 ratio for flexion and abduction. Now you're not going to have to do any math, but again, just remember, like I said, to get 180 degrees of full flexion, we're actually getting, or abduction, we're getting 120 degrees at the GH joint. Then we got to get the other 60 from the upward rotation of the scapula to give us our 180. So, and I know here it says 30 and 30, and it said like 25 and 35. You don't need to necessarily remember that, but we need to understand that motion is coming from the sternoclavicular and the acromioclavicular joint. And this is why those clinical insights are awesome. Read that clinical insight and learn how that can lead to impingement at the shoulder. So now we need to get into these rotations. These rotations are an example of a force couple. We have 2, 3, 4 muscles that are pulling in different directions that create one motion, rotation. So again, we need to start learning muscles, nerves, actions, so we can understand if someone has weakness due to a nerve injury, what we could see. So let's look at upward rotation first, because this is the one we need. This is to have our full abduction. So this is going to be a right scapula, because then you can imagine the humerus being right here. Okay. So some of our upward rotators, we should already know this because I just talked about it, are upper traps, upward rotator, lower traps, upward rotator, and serratus anterior. Those are our 3 major upward rotators. So I'm going to go over here to the muscle pictures, just kind of show you how those work. How does the upper and lower traps help you with upward rotation? So I want you to remember, upward rotation is the scapula, the inferior border, moving up and out. So we got to get this to move this way. So how are we going to do that? Well, we're going to pull these upper traps are going to pull the scapula up this way. Now I want you to see the lower trap here. If here's the muscle fibers, what's the line of pull? You can see how that's going to pull down. So we're pulling up here, we're pulling down here. You should be able to start seeing that rotation occurring. Here, let's do the red. You should start to see how that's going to start to take that inferior angle up and out. Now, to really make a nice force couple, we need a 3rd muscle here. And that's where the serratus comes in. So the serratus is going to originate on the rib cage and insert on the medial border all the way over here underneath on the scapula. So 1, it helps keep the scapula against the rib cage. So it helps with that scapulothoracic rhythm there. So I want you to, as a bonus question, if you know the answer or figure it out, please put it in the comments. But what happens if we have a weak, besides upward rotation, weak serratus? What is that going to cause? As a just observational assessment, what will you see if someone has a weak serratus, or what could you see? So, but back to the upward rotation, it's going to help pull that scapula. You can just see this here now. If this connects here and it's pulling this way, you can see how it's going to pull forward. And those 3, upper trap, lower trap, and serratus anterior, are going to be your upward rotators. And we need to understand eventually how to strengthen those guys, how to test the strength of those guys, and improve that motion. And we should be able to know that when you upwardly rotate against gravity, the same muscles work to lower your arm and scapula back down, just eccentrically. And if you're not getting that, you need to talk to me about that, or you're going to get destroyed on the exams. And it's not going to be good because you're just simply not going to understand the biomechanics of the shoulder. So let's look here now at the downward rotation of the scapula. So there's, I got 4 muscles on here. So we have our levator, rhomboids, pec minor, and lats. So you get to check out the pec minor. I did not take a picture of that, but I'm going to look at the levator, rhomboids, and lats for you. Okay, so let's go over there to those guys. So let's take a look at the rhomboid. So with downward rotation, if the inferior angle is upwardly rotated, so it's up here, how do we pull that back? So let's say you're doing like a lat pull down. So your scapula would be upwardly rotated. So how do we pull down against the force of the pulley machine to get that back, to downwardly rotate that scapula back down? So we're looking at the line of pull of the rhomboids here. If you think about how these guys would contract, if this scapula is moved over to the right, well, they're going to pull it back. They're going to bring that medial border and inferior angle back towards the center. So that's how they downwardly rotate. Now let's look at the levator up here. So if I were to be in an upward rotated position, you see the superior border? Here, let me erase that and make a different color. See the superior border or the superior angle of the scapula? Where would it be if I was upwardly rotated? It would be down a little bit. So you can clearly see the line of pull of the levator is going to pull that back up. So the rhomboids are going to pull it back towards the middle, and the levator is going to also help pull up, bringing you back through that downward rotation. Now let's look over here at the lats and what they're going to do. A very small portion of the lats, look over here on the left, connects to the inferior border of the scapula. Right there, it's going to tell you what it's going to do then. So when you think about this huge muscle contracting, what do you think it's going to do to that scapula? It's going to definitely pull that inferior angle. If it was up here, because it was upwardly rotated, it's definitely going to bring it back. Like I said, on your own little homework, look at that pec minor and just look at the muscle pull and line of pull and see how that's going to help downwardly rotate that scapula. So those are 3 excellent downward rotators. And then you add the pec minor, gives you 4. Now we're going to go back to the lats because we're going to talk about reverse muscle action with the scapular depressors. So things that help bring that scapula down. Now you're going to see the pec minor, subclavius, lower traps do it, but what's the biggest muscle? It's going to be the lats. And this is really important for assisted devices and transfers for all of us. So let's take a look at how the lats help us with assisted devices, which you're about to do in your other classes, I'm sure. So let's think about if you're sitting on the edge of, you're sitting on a table and you got this little plunger system here where you could push your elbow down. So the lats are going to pull down on that inferior angle of the scapula, and they're going to pull that whole shoulder girdle down, okay? So what would happen if this would actually go down is you could push, if you sit in the chair now with arms and you push down, you can feel your scapula depress as you push into the arm of that chair. But the chair doesn't move. So what happens to you is you start to lift up. Well, that's the reverse muscle pull. So if we get rid of that plunger and we just make it something that's not going to move, like the arms of a chair or a bed that you're sitting on or a plinth or wheelchair arms or crutches, then what actually lifts you up? What muscle is engaging to get you on the crutches to not shrug your shoulders so your shoulders are up in your ears? How do you get your shoulders away from your ears? You have to use your scapular depressors. So the reverse muscle pull of the latissimus dorsi is what allows you to unshrug when using crutches, or if you're trying to get out of a chair. That helps get you up. So if you don't have lats, your shoulders are just going to jam up into your ears, and then you're not going to be able to transfer or use assisted devices. So this is a really important exercise to strengthen by making sure we maintain optimal strength of the lats so that we can use assisted devices and transfer out of chairs and beds and scoot and all that kind of stuff. And we'll be talking about that more throughout the other classes. But very vital component is that latissimus dorsi for using those assistive devices. Arthrokinematics, pretty much you're just going to need to pause on this here. Here are the answers we're going to have for the exams. So I'm trying to see, I don't see a slide on any of these, so this should hopefully get you the answers that you need. If you have questions about the arthrokinematics, please let me know. These are all highlighted here, open chain. Moving on to muscles here. There are so many muscles at the shoulder. Start with the rotator cuff first. Learn it, know it, memorize it. You should be able to go nerve, muscle, action. You need to be able to do that. So at anywhere along the way, a question can be asked, you can answer it, okay? So the supraspinatus you're going to read is going to do abduction, yes, but honestly, one of its most important things is that it helps depress the head of the humerus into the glenoid fossa. Injuries to the supraspinatus, which are the most common of the rotator cuff, lead to issues with that depression of the humeral head into the socket. And then you start having multiple other issues. So make sure you check those rotator cuff muscles out, okay? And I already talked about the 4, but you go back and look at them, but I want to point out that supraspinatus and its importance. We also talked about the latissimus dorsi. It helps with internal rotation, but it's not part of the rotator cuff. You're going to see there's a lot of muscles that help with other rotations, but they're not part of the rotator cuff because the rotator cuff is going to have muscles that insert on the greater or lesser tubercle. Everything else inserts somewhere on the humerus, so it's just technically not considered a rotator cuff muscle. Now the teres major is the lat's little helper. So let's take a look at the teres major. Where did I put that guy at? Here we go. Teres major. So it's going to help extend the shoulder a little bit, and it's going to help to adduct the shoulder. 2 things the lats help do a ton of. So it's going to help with extension and adduction. Okay. It is not part of the rotator cuff. See, it's not inserting on any of the tubercles. So teres major, lat's little helper. Biceps. So the biceps have 2 heads, long and short head. So let's take a look at the bicep. So first, let's point out the short head of the bicep. It is going to originate on the coracoid process right here on the scapula. Okay, this is a spot we should be able to easily palpate on patients to see if that's irritated or sore. But then what really we need to be paying attention to is the long head of the biceps. So it's going to run up between in the bicipital groove between your greater and lesser tubercles. So you should be able to see the sucker running up there on top of the head of the humerus. And it inserts right here. And that is the superior portion of the glenoid fossa. Now, if you have what's called a slap tear, superior labral, tells you right there. Superior labral. So superior labrum has been torn. And now, because we've just talked about basic origin and insertion, what originates at the superior labrum? The biceps. So if the biceps originate there and someone's had a slap tear, they've had a repair, we need to start being able to think about what you should not be doing until it's healed. Well, number one, we know the biceps are going to flex the elbow, but they also flex the GH joint. And what's a third one that's oftentimes missed because it's a test question? What is the third thing the biceps do? I'm not going to tell you. You can look that up. If you think you know the answer, put it in the comments and I'll let you know if you're right. But this is the one that people always miss and forget about. And it's very important early on when things are healing to not do this third thing because it's the one that's forgotten. And we can't put stress on the bicep. So that's your slap tear. Some common mechanisms of injury, because we're looking here, it's a superior labral. The shoulder is going from anterior to posterior. So common mechanisms of injury. Falling on an outstretched arm, like you fall forward, like you're in a push-up position, you fall forward. Dislocations, forceful movement with arm overhead, for example, throwing. And a motor vehicle accident. You think you're holding that steering wheel and you get in the wreck, your humerus is going to go from the front to the back. That's your anterior posterior. And then you have Bankart lesions, which will be talked about more in patho, but they're kind of the opposite. The injury is going to happen at the inferior portion of the labrum, oftentimes due to dislocations, especially if the arm is abducted with external rotation and there's impact. So we'll talk more about that, or you'll talk more about that in patho. But the main one right now, I want you to understand, is that slap tear, slap repair, okay? We've talked about the serratus anterior. We should know by now that it's going to protract the scapula concentrically. It helps with upward rotation, and it holds the scapula next to the rib cage. So some pathologies. I talked about the two types of labral tears right now. I did not talk about winging. Where does that connect to? Right? I asked that question. So I've already kind of told you, but I want you to think about what was the nerve that would affect the muscle and how would we get this winging? So if you hear winging, what is that referring to? I think you should be able to easily figure that out. Plenty of hints in this lecture. We did not really talk about subacromial impingement yet. I wanted you to look at the rhythm on your own to see how that could lead to impingement. But in general, there's multiple types of impingements. So let's take a look at some of the anatomy here. So when you look at the osteology, it looks like there's tons of room between the acromion and the head of the humerus. There is not a lot of room. So if we have issues with the arthrokinematics, as you see in this picture here, what's going to happen is when your shoulder goes to flex or abduct, it jams up and hits on the head of, or the head of the humerus hits on that acromion, smashing that bursa. So it becomes inflamed. And what is the muscle here? The supraspinatus. This is why it becomes one of the, or it is one of the most, it is the most injured rotator cuff muscle. It could be injured because of the subacromial space being compressed due to the subacromial bursa being inflamed. Also, if you think about the supraspinatus and then the bone that is the acromion, imagine having a rope and every time you're lifting up over your head, you're just taking a machete and hitting it. But it's a real hard anchor rope, so it's going to take a long time to chop through that. But eventually, it happens. That's why a lot of times you'll get patients who are like, I don't know what I did to tear my rotator cuff. I just lifted up my lunchbox, you know, like I do every day. Well, that was finally kind of like the straw that broke the camel's back. So we need to understand how this bursa and this subacromial space affects getting different pathologies and how we need to work on treating those next term. And why the arthrokinematics, as you see up here in the normal picture, are so important to work on. That's why we need to understand those arthrokinematics. If there's a lot of inflammation, then the coracohumeral ligament is often removed to help free up some, coracoacromial ligament, is often removed to help get some nice space here. Okay, so if you remove this ligament, now we have more space for that inflamed bursa in that subacromial space. So don't pay attention to this blue thing here. Pay attention to the coracoacromial ligament that's above it. Okay? There's a lot that can be discussed with impingement. Again, we'll talk more about that in term 4 because that's when we actually work on treating, and you have the patho class. Those are some very basic concepts to start off with. So now we've covered subacromial impingement syndrome, talked about the rotator cuff, poor posture. So we will talk a ton about this, but as you have poor posture, you start to mess up that scapular thoracic rhythm. Your shoulders become overly internally rotated. You lose the ability to flex or abduct. Even right now, sit with poor posture, super poor posture, and try to flex your shoulder. You're not going to get 180 degrees. Sit up straight. Are you able to go a few more degrees? Yes, you're going to be able to. So that posture is super, super important. And frozen shoulder, also called adhesive capsulitis. So once you think about that capsule that surrounds the shoulder, if you get inflammation that is not treated and it becomes chronic, you start to have adhesions. I like to think of the capsule as a little bit like your shirt. When you go to abduct your arm, your shirt has to give a little bit, right? Just a tiny bit of a stretch. So imagine adducting your arm all the way to your side, your shirt's scrunched up under your armpit, fill that with super glue, let it dry, and then try to abduct your arm. It's not going to go because your shoulder or your shoulder is going to be restricted by the shirt that's not giving. Well, that's what happens with adhesive capsulitis, except it's way more painful. And this is not a fun thing to treat. I saw a lot of it and I hated it because there's really one way out of this. Two ways: time. Well, I guess you could say a third way: time, surgery, which they don't want to do, and intense therapy mixed with time. And it's just a lot of stretching, it's a lot of mobilizations, and it's a lot of pain. And it's really hard for patients to deal with that. You got a lot of nerves going through that area, and it's a lot of work. So trying to prevent adhesive capsulitis is a great deal of importance. How do we prevent it? Well, we keep moving the shoulder. Problem is people hurt the shoulder and then they stop moving it, or they start to have adhesive capsulitis start. So they stop moving the shoulder. And by the time you see them, they've lost almost all their motion. So they're already in that frozen stage. So it's very important post-surgery or even post-injury, to at least have passive range of motion to keep that joint healthy. Oops. All the windows are opening up here. All right, so let's just double check to make sure we've gone over all the important stuff. Here's just another picture of that supraspinatus. So you should be able to see how it's running underneath this acromion. Every time you abduct, if you don't have proper rhythm, then you're going to have impingement. I also feel, this is my own little soapbox, that doing military presses overhead are really not necessary. Why do you need to do that? Unless you have a job where that's happening, and even then I'd say your job probably is making you strong enough. Do you really need to do that? That's why a lot of weightlifters who do that, what do they have? Shoulder problems. Because of this, most powerlifters and people I've met are always like, my shoulder kills me. It hurts my bench press sucks now, or overhead, but they're 80 pounds trying over their head. It's just obnoxious. So I don't feel that that is a necessary functional exercise to do, but to each their own, and it helps keep therapy in business. So that is your lecture on the basic lecture on the shoulder. There's tons more in that chapter, great nuggets in the clinical insights, things like that. And you'll learn even more, obviously, in class, on your own reading, and the next term when we get into pathologies and actual treatment for the shoulder. Make sure you take the quiz in the description for this, and subscribe and hit the bell for notifications so you can get the most immediate uploads that I have for you here, so you can stay in the know.